Hello, and welcome to Wellness Wednesday with 3W. Wellness Wednesday is sponsored by 3W Medical for Women, a nonprofit medical clinic offering free of charge or low-cost women's health services in the Seattle area, regardless of income or insurance status. 3W does not profit off of the health choices women make. The information shared in this podcast is the opinion of the speaker or speakers. Medical information is not intended as individual medical consultation, but for general education only. Always talk to or consult your own health professional for personalized advice regarding medical decisions. And if you're in the Seattle area, consider making an appointment to consult with us. I'm Helen Nguyen, CEO of WAMS/3W Medical for Women, and the host of today's podcast. Hi there, Wellness Wednesday listeners. Thank you so much for tuning in. This is yours truly, Helen Nguyen, CEO of WAMS, Women's Accessible Medical Services. We're going to be reintroducing our corporate name into our marketing and branding a little bit more, just because why not? It's always good to pay tribute to who we were from the very beginning. And as you probably all know that, we have a program called 3W Medical for Women where we practice medicine and provide medical services and healthcare services to the women in our community. But you're tuning in today to listen to a really, really cool presentation that I was able to watch in person live, presented to this really, really cool symposium that I was able to attend through the Institute of Reproductive Grief. And we have Megan Wells here today with us, who is a licensed therapist out in Northwest Montana. She's also licensed in the state of California. And her presentation was all about the missing trimester, which I was like, brilliant name. And her presentation really, really stood out to me. And I'm so grateful that Megan is available today to jump on a quick Zoom call and record this podcast with me, because I think her approach and her language and the way she's communicating this missing trimester when it under the umbrella of reproductive grief was just brilliant to me. It really resonated with me. So, hi, Megan. Thank you so much for spending time with me today.
Thank you, Helen. I'm just really delighted to be here, delighted to meet you and to get to talk to you and your community about this work.
Yes. And I could tell when you were presenting that your heart is like, this was a work of passion for you and dedication. And I just want to capture it and spread it all around and spread it to the women here in Seattle, Washington. So I'm just going to let Megan dive in, and we'll kind of link some information that she brings up and talks about. But please, Megan, please tell us more about yourself, how you got involved in reproductive grief, and why are you so passionate about this missing trimester?
Sure. Thank you.
Yeah.
So I've been in practice since 2012, and in 2018 started working in the realm of perinatal mental health. And right away after doing my initial training was receiving referrals for people that were navigating a wide range of reproductive grief events, from fertility challenges to pregnancy losses to stillbirth and neonatal loss. And what I began to see over time with these clients who I have the privilege of serving is that in addition to the just poignant pain that is reproductive grief, it's such a unique kind of grief. In addition to that, and for most of the people that I serve, there's also, there's grief plus anxiety, or there's grief plus depression, or grief plus trauma. That's already a full plate for somebody.
Yes.
Right? But what I kept seeing over and over and over again was this set of compounding factors on top of the grief. And those compounding factors had to do with things like receiving insensitive comments from people, sometimes with really loved intentions, like from loved ones, from friends, from medical providers. Things like a lack of resources or a lack of information, leaving the hospital and not being given any information on what to expect, or any information on support groups or therapy. And then things like judgment, like people coming into my office and feeling so much judgment about themselves for how they were navigating the grief and how long it was taking, or experiencing judgment from the outside. Like,
Mm.
why are you so sad?
Mhm.
Why is this taking so long? Why aren't you back on your feet? Why are you still talking about it? So these compounding factors I was seeing, and something inside of me, I think I have one of those brains that's always thinking upstream. Like, okay, this keeps showing up in my office, and we do the work of therapy in the therapy room, and I hold that really sacred. But I kept seeing these compounding factors that were happening outside of the room. And this question arose in me of, what is missing here? What is missing that is allowing this to keep showing up for people over
Mhm.
and over again?
Mm.
And what came to me was from a theorist. He was a pediatrician and a psychoanalyst. His name was Donald Winnicott, and he worked a lot with infants and primary caregivers. And he came up with this term called the holding environment.
Hmm.
And the holding environment is this psychological and physical space where somebody's internal experience can be met by compassionate and understanding others.
Mm.
So it's like, these people that are grieving, is there a way that the community, that family, that society could be a holding environment
Mm.
for reproductive grief?
Mm.
And so that's really how the missing trimester was born.
Wow. That's so cool. The holding environment. That's such
Yeah.
an interesting way of identifying that missing piece.
Yeah, some the language that I often hear from clients, like, people leaving their OB or midwife office after a loss, or after a failed IVF cycle, and I hear words like, "I felt dropped," like
Mm.
they just sent me on my way,
Mm. Mhm.
said, "Come back when you're pregnant again," or, "Come back when you're ready to start the next cycle."
Mhm.
And there's so much that is lost in that dropping,
Mhm.
and I find that people really need to be held,
Mhm.
and grief needs to be held, right? And not just
Yes.
by individuals. It's too big for individuals to hold this kind of grief. It needs others. It needs partners or family or friends or loved ones to be able to hold it with us.
So that kind of set the tone as you dived in deeper into this missing trimester kind of work.
Yes. Once the need was really clarified for me, I began to look at, what are the pieces that are missing, within this kind of umbrella of this, or this concept of the holding environment. And what came out of this several year brainstorm was these three foundational elements.
Okay.
And the first element is community education.
Mm.
you know, People that go through this experience, or it's actually like a broad range of experiences, right, under reproductive grief. But anytime someone goes through these experiences, if they don't have people around them that have either gone through it or have information around it, the experience is often really isolating.
Mm. Mhm.
And so community education, I believe, is so important because we need to be able to feel understood in our
Mm.
grief. It's such an emotional labor to be grieving, and then to try to explain it to people. So this idea of community education is, one where, could could medical offices be informed so that they know, okay, these are the things we need to be sensitive to when someone is struggling with fertility, or longs to be a parent, or is going through loss? And to have that already sort of built into a system makes a huge difference for somebody. It means they don't have to go through that disenfranchised grief process on top of the grief. Community education is a really big component. And the second foundational element is provider support. I feel really passionate about, I do a lot of continuing education, and I work with a lot of different kinds of providers and collaborative care. And one of the things that I hear about so often is providers being asked to do more and more and more,
Mhm.
often with less time and less
Yes.
resources,
Yes.
right? Like, that's kind of a
Always.
lot of yeah.
Always. Yes.
It seems to be just the era we're living in right now, and I've had so many clients have difficult experiences with medical providers, and I have this really deep belief that, people that go into the medical profession or the mental health profession are deeply caring people.
Mhm.
And so the question that kind of came through this missing trimester work is like, rather than asking providers to do more, like, okay, now you need to go through this checklist with your patient, or you need to say X, Y, and Z every single time. Those things can be important. Information can be really important. And like, what is happening for the providers that they're struggling with the grief of their patients? What is happening for them in the stress of their day, in
Mhm.
their lives, in their week? And so the question became rather, instead of what can providers do more of or do better, the question the missing trimester asks is how can we help providers feel better?
Mm.
And I began to research the rates of stress and burnout in providers, and it's staggering.
Mhm.
I imagine you see it in your work.
Yes.
It's
Yes, especially in reproductive health in general. There's this, the providers that we have care deeply about each individual that walks through the door because we understand a hurdle that that person had to jump through to even get through our door, right? Because everybody has a story, everybody has complications in their life, and then having to potentially retell, the same story, hoping that this provider will sympathize, empathize in some ways. And we encourage that sometimes after a really hard visit with the patient, that provider takes on the grief, takes on the heaviness of that conversation. And so we really encourage our providers to be like, okay, let's talk about it. Let's not ignore it. You're not a robot. Let's take a walk. Let's go grab a coffee. Like, let's honor that moment that you had to go through and hold someone's hand while they're just devastated about the news or, disclosing something that was so painful in their life. That's really a lot to ask from a provider.
absolutely,
Yeah.
absolutely.
Yeah.
Yeah. And what I see so much is there's no, like you just talked about a really lovely sort of holding environment for your providers. Like, you
Mm.
give the space, you encourage that kind of regulation or
Mhm.
processing or those intense appointments. And for so many providers, that's not the case. There's no holding environment, right? They
Yes.
they go they go from, appointment to appointment to appointment,
Mhm.
and then they go home for the day, and there's no space.
Mhm.
The missing trimester, it's really important to me that providers feel like they can also have their emotional well-being be part of their service.
Mhm.
And like you said, especially with reproductive health, especially with perinatal loss, I think it's essential to have skills and have practices and have spaces where providers can go to be able to process some of the things that they hear, some of the things that they see, so that it
Mhm.
doesn't have to be carried and just accumulate over time. We know that has, mental health implications. We know it has
Yes.
physical health implications. And so it feels really important to me that we create spaces and we create skills and tools for providers to feel like they can use their innate gifts and their training and their amazing education
Mhm.
and have sustainable careers doing it.
Well, it's a two-way street. You would think it's logical in the sense of like as providers, you're asked to serve and love and provide services, but my position is to also protect my providers from being burnt out, from just being treated like a robot. Okay, I need you to move on to the next patient. I need you to move on to the next patient. Because that would be, in my opinion, that's not good. That's not good healthcare because if the provider is not in a good spot, herself or himself, how are they supposed to provide good care to the person that's asking for care? So I don't really understand. Like we have here at 3W, we have the luxury of really honing in because every appointment is up to an hour with our patients, right? And then even afterwards, we're allowing our providers to be human and come to us and say, that was really hard. I need a break. I need 10 minutes. I need to talk through what just happened. I need to go into my office and cry.
Mhm.
Just providing that space. And that is so honoring of what they just did and honoring for the next patient that's going to be seen. But
So
that's not something weird, right? So I don't understand how major hospital systems can just ask you to go through patient after patient after a patient. You become kind of like disconnected and disingenuous to the type of care you're providing. So it's a full circle situation where if I'm taking care of my provider, then I'm doing good patient care because they're able to care well for the next person they're caring for. But I don't understand why this very logical thing isn't incorporated into medical education as a whole. Like it's just very glossed over. Or people say like nice things like buzzwords like self-care and
Mhm.
work-life balance, but what does that really mean? How do you put that into practice, I guess?
Yeah, it's so like you're saying, it's so logical and yet so rare, you
Mhm.
know?
Mhm.
And it's really beautiful to hear the way that your work and your clinic runs because I can hear the health of the system,
Mhm.
right? Like when the system is attuning to each level, like the patient and the provider and the front desk staff
Mhm.
and the schedulers, like the whole ecosystem can be well. And each piece of that is so important.
Mhm.
So many of the stories I hear from clients when they have these disenfranchised grief experiences at med offices. It's like they find out at their ultrasound that they've lost their pregnancy, but then they go to the front desk and the scheduler says, "Okay, let's get you scheduled for your next checkup."
Yeah.
And all of those glitches in the system
Mhm.
that can have such a damaging effect, unfortunately, to the person who's in the most vulnerable moment. I just really appreciate your systemic approach to health and healing.
Thank you. Yeah, I think that's the benefit of being a small little clinic and how working together to provide the best care possible. What does that look like? And that means it starts from us. We need to model what good care looks like in order for the patient to recognize what good care looks like. But, that scenario you just talked about in the sense of you just had a loss in the exam room and then the receptionist is like, "Oh, let's schedule you for your next ultrasound." I wholeheartedly believe that that was not out of insensitivity, right? That was not out of like a dig or something like that. But when you get so systematic in the type of medical care that you're receiving, you're just another number in the machine, you lose something. You lose the human piece of it and you lose the heart of why medicine was even created or why medicine exists in the first place. And yeah, I remember for my own fertility journey, I remember going to these facilities that have had very high success rates. So I was very willing, right? Really a willing participant.
Mhm.
But the insensitivity to me being, I described one of my visits as feeling like a plucked chicken. Like it was so, it was so mentally exhausting. And I honestly believe the people that were serving, it wasn't because they didn't care. They probably just didn't have the tools and the language and the capacity to even realize the quote unquote damage or in little pokes here and there that caused me to walk out of an appointment going, yeah, I don't want to do that anymore.
Mhm.
Yeah, I don't want to be a part of that anymore.
I'm so sorry that was your experience. I have so much compassion for all the sides of the experience. I think about I think about the privilege of my position just being a therapist. I don't have all the procedural tasks that I also have to accomplish with someone and be really emotionally attuned also. I don't have to code switch as much as, medical providers do. So I really have a lot of compassion for the task at hand of being okay, I have to get through all of these things, make sure this person has their blood drawn, make sure that they get the meds at the right time, all of these things, and then drop in and go, "What questions do you have? How's your body taking this in right now?" It's a lot, and one of the things I talk about in the missing trimester in terms of provider support is the difference between empathy and compassion. One of the things that I see a lot is that contributes to burnout, or when a provider is already kind of on the road to burnout, there's something that feels inaccessible about empathy. Like my tank is already empty. I have nothing to give. One way we can define empathy is like seeing a person suffering and joining them in it. So it's like this meeting of someone in their suffering. And for a provider that's already experiencing burnout, like, that's such a huge ask. Join someone on their worst day when your tank is already empty, and so I really like talking about this kind of alternative path of compassion, which is seeing a person suffering and feeling motivated to serve, not to fix, but to serve. Like, what can I do just with my presence and being here that will let you know that I'm accompanying you or let you know that I see you? And then what can I do in terms of resources or in terms of connecting you to other supports to kind of wrap around you to let you know that we understand what a huge deal this is and we want you to feel cared for in it. But for that provider to not have to like take on the weight of it, but to really, you know, still witness it. I think
Right.
it's a skill set.
Absolutely. And I think, being in that patient position as with my walk with infertility, you can tell when empathy is not genuine. You can
Yes.
tell when it's just like you're just saying words. And it's, again, it's not, I wholeheartedly believe it's not because they are meaning to do that, but they need their mind is already to the next patient. And so they're saying things. And so I can sniff out disingenuousness. And it's like, you're just saying that and you're not validating, you're not even giving space, you're not giving pause, you're just saying it. And I want to give you the benefit of the doubt that you mean it right now, but your mind is already to the next appointment. Your mind is already
Mhm.
to the next issue. And
Mm.
that could be walking out of something like that could also be like, okay, thanks for dismissing this feeling or minimizing it or glossing over it. And it makes you wonder like if you're crazy as a patient. It makes you wonder like, oh, am I supposed to get over it in a very
Right.
calloused way? Not moving forward, but getting over it. Because
Mhm.
this person I'm disclosing all these emotions to or these feelings to just totally just said a bunch of buzzwords to make me feel better.
That's where I'm so glad you're speaking to this because this is where, in previous trainings that I've done, I was getting caught because providers are given language. What I talk about in the missing trimester is working at the level of the nervous system and working at the level of nonverbal communication. Like
Mm,
nervous systems can know if the words match the feeling, right?
mm, mhm,
Like, even little kids can pick up on that,
mhm,
right? Like, little kids, it's something that, is a wisdom that I think we're born with. Like, when does it match and when do the words and the feeling not match?
mhm,
And that matching, like you're talking about, is so important in order to convey safety, right? Like, our nervous systems, our stress response systems will immediately kind of go, "Ooh, something is amiss here." Like,
mhm.
Is it them? Is it me? Is it this experience that I'm like doing it wrong? Are they doing something wrong? It really kind of triggers our stress response when there isn't that congruence between what's being said and what's sort of resonating at the level of the nervous system. And so I'm so glad you brought that up because in the missing trimester, we talk a lot about how to help providers regulate their systems so
Mm,
that their tone of voice, their facial expression, and their eye gaze can communicate safety,
mm,
understanding. I'm not in a rush. I'm not scared of your grief.
mm,
Walk with you in it. And I'm
mm.
here to go over the information as many times as we need to go over it.
That's beautiful. I'm not scared of your grief. Yeah, I think as women, we have this intuitive gut feeling of when someone is being disingenuous or just saying
Yeah.
things to us, especially in that moment of vulnerability too. And so there's this internal fight of like, is this person being truly empathetic and sympathetic to my situation or what? And so it's like you're dealing with the grief and then you're having to translate what this person's telling you. And then you just walk out just exhausted emotionally on what that,
Absolutely.
and it shouldn't be like that for the provider, and it shouldn't be like that for the patient.
I think it was in one of Nikki Berry's research papers that, she found that the emotional experience of reproductive grief wasn't even considered, wasn't named, wasn't studied prior to 1970. It wasn't even the emotional experience was not even part of the picture.
Hmm.
It was only, okay, what has happened medically, what has happened to your body, here's what you need to do, go forward. There was no tracking of the
Hmm.
emotional experience.
That's wild.
Isn't it?
That's crazy. I mean, there's a time and space for the more technical piece of it, right? The patient wants that, but then how do you humanize it?
And the way I was trained, the definition of healing is different than the definition of curing. The people that I studied under, taught me that healing is about wholeness. And so if we're
Mm,
leaving out the emotional experience or the psychological experience, we're missing the healing opportunity to include someone's wholeness in their grief experience.
that's beautiful. See, you always know what to say. That's so beautiful. Healing versus curing. It's like that's so cool.
Yeah,
Yeah.
because for a lot of people, there isn't a cure, unfortunately, in reproductive grief. For a lot of people,
Yeah.
you know, live in this culture or this society that at least a lot of us, sort of grew up in with the belief that if you work hard, if you do the right things, you'll get the outcome you want. And fertility does not play by those rules.
Mhm.
And that can be so difficult.
Mhm. Yeah, especially with the lack of attention to women's health in general. There's a
Yes.
lack of understanding the complexities of our bodies till this day, surprisingly. And to our cycle. I mean, that's a whole nother, topic that I talk about a lot on our podcast is like our cycles, and then what is motherhood, and what are our bodies and expectations of that we put on ourselves as young women and as we mature, right? And then I was just reading something, this is a tangent, but I was just reading about how in the US we have like the highest number of hysterectomies like across the world. Like we just do an alarming number of hysterectomies. And are we addressing the mental health issues that comes with that, or are we just saying that's just what we do, And I interviewed a podcast guest that had to do an emergency hysterectomy one time, and I just asked her, I was like, "Have you grieved? Has grief hit you, or when you were moving forward with it because it was a necessary medical situation? Did anyone ask you, like, as a woman, how did that make you feel that you had to now go through this process, and what steps did you take to grieve this piece of your body that's no longer in your body? Just things like that that carried your babies, that was a safe space for your babies and all of that stuff. So,
Well, I think like you're really shining a light on reproductive health in general for women has been so shadowed. And it's so, so many of the interventions are really kind of like blunt instruments. There's not a lot of nuance. There's not a lot of emotional kind of sensitivity to something that is so deeply intertwined with our emotional health, right? Our reproductive psychological health are so inextricably linked, but they're treated so separately. It, and I think that's where we miss a lot. I think, back to that idea of being dropped. I think a lot of women or people with uteruses feel dropped because the whole psychological component, like you're saying, isn't being asked about, or people aren't given resources or referrals for. And that's really an area, I think, a growth opportunity, right?
yes, yes. And I think the Institute of Reproductive Health was the first organization that recognized reproductive health or reproductive grief as a real thing.
Mhm.
One of the profound things that when we went through as an organization through the training that Sarah did for us was when we have these assumptions of especially for women, I think we have these assumptions of like, okay, we have this amazing superpower to carry children, create life, all of that stuff. And so there's this tape that we've played in our brains subconsciously from an early age of getting married, and then you have kids, and then what does those kids looks like, and it's going to be this beautiful amazing thing. And then when that doesn't happen, it's like our brain circuits, it's like, whoa, I'm broken, I am unlovable, this is all I have. Regardless of all these other accomplishments that we've had as women, there's still this loss when we are not able to produce life. And it's, for me, it was kind of like at some point I was like, well, what is my body good for? And it,
Mm,
it allows these false negative, thoughts to penetrate our spirit and our mental health when we know logic. I knew logically that was not true, right? My body is made for much more than what I am reducing it to. But in that moment of vulnerability, no one was telling me anything different because that was my hyper focused on that piece. And
yes.
it wasn't
Yeah.
until we attended the training, the reproductive grief training, that I was like, "Oh my gosh, that's why I was feeling this way." Beautiful connection in my brain, at least.
So powerful. It sounds so powerful when something gets named that we've been experiencing without a name, and then we have a context to put it. It can be so relieving, right? It can be. And what you're speaking to reminds me of something that I see a lot, which is, in addition to the grieving itself, reproductive grief for a lot of people has this like distilling quality, like all of the faulty beliefs or all of the social conditioning or all of the trauma. It's like all of it kind of gets distilled in reproductive. And, the therapist in me is like, wow, that's amazing. Like, what a healing opportunity we have to look at all of these things that maybe, if grief hadn't happened, we would have just kept going through life and they would have been livable things. But in the grief, they become so apparent and so acute and so painful. And the therapist in me gets excited about that, and the human in me is like, "Are you kidding? Like, we already are going through this horrible, painful thing, and now I'm having, these beliefs and these memories and these, judgments." And so it can feel like a lot. It can feel like a lot for people to have to navigate, and that's part of my passion for the missing trimesters also is that, you know, I don't want people to have to navigate it alone.
Well, that's so much why I appreciate your presentation, because it just again shown a spotlight on words and approaches that I've just never was exposed to, and even our medical providers, when we've put them through the reproductive grief training and we've given them your slides and from your presentation, they're like, whoa, why wasn't this a class, during medical school? Because it's not like we weren't going to not serve these patients. And it just clicked. It was just really, even though these are very empathetic women, compassionate women, it just gave them further tools to be even more present and more genuine in the walk with our patient population who are suffering greatly. So yeah, just thank you so much for this language and this intentionality behind this missing trimester. So just going back a little bit, you talked about, I wrote down 3 pillars, but I'm pretty sure I'm totally not correct in that. But so you talked about community education, provider support, and what was the
Yeah.
third one? I'm sorry,
The
I
third
interrupted you.
No, I'm glad you circled us back because my brain doesn't always circle back, so I'm so glad you did that.
No, you're totally fine.
The third pillar, the third element of the model is
Yeah.
person-centered care. So person-centered care, I think, is a little bit of a buzzword
Mm.
in medical field right now,
Mhm.
but in the missing trimester, it's really how can we be as trauma informed as possible? How do we bring evidence-based research into individualized care
Mm.
rather than sort of slapping like evidence-based, here it is, but it's the same thing for every single person who walks through the door?
Yeah.
How do we individualize? Because reproductive grief and perinatal loss are so unique to each person and to each loss, and it's really important that we see the people that we're serving clearly. And what that means to me and to the missing trimester model is seeing, what are the hierarchy of needs here?
Mm.
Like, are there safety and survival needs that this person is dealing with on top of their loss?
Mm.
Is there interpersonal safety concerns?
Mhm.
Is there a history of trauma, either generational trauma or sexual trauma? Those are such important things to know when we begin to work with someone who's going through a loss, because their loss will be expressed totally differently based on the context for them. Things like systemic and institutional oppression and
Mm.
racism,
Mm.
those show up hugely in reproductive health and reproductive loss. How do we help people feel like no matter what has happened to them, that in the process of grief, that they are the ones that have choice and
Mm.
they are the ones that get to use their voice
Mhm.
for how and when they process their grief. When I was doing my grief training, I worked in hospice back in 20, I think I started in 2011, and the predominant model for grief back then was kind of confronting the grief. Like, let's go into the grief, let's
Mm.
really feel it. And now I work a lot at the missing trimester presents with the dual process model, which is this concept where there's loss oriented grief, which is like being in the hard parts of grief, but then there's restoration oriented grief, which is like taking breaks from the grief or being distracted from it for a while or doing new activities or trying on new roles. And we actually want to go back and forth between those two zones.
Mm.
So when someone's coming to us and they're navigating grief or loss, we really want to be sensitive to, like, is there safety enough in their environment, in their relationships for them actually to go into the grief?
Mm.
And if there is, how do we help them kind of oscillate between the grief, the loss oriented and the restoration oriented grief so that there isn't a stuckness or an overwhelm? Sometimes grief can feel really overwhelming to people, especially if there's a trauma history. It can be really overwhelming. So person-centered care is really applying these evidence-based concepts and practices, but really individualizing them to the
Mhm.
person serving.
Mhm. When I hear you talk about individualized care and not this massive umbrella of a diagnosis to everybody that walks through the door that has a miscarriage or post-abortion or whatnot. And it's like, you know what I think, you know what I think of? I think, wow, it takes time. And in our world right now, we don't have time. In our world right now, time is connected to money. And what does that transaction look like? And I think for your typical provider that goes into medicine, their heart is to heal. Their heart is to create space that is healing, wholeness, wellness. The medical system right now is not connecting with that. There's an emphasis on the transaction versus the healing part of things, right? And individualized care is it's just too hard. It's just too hard and it takes too much time. You know, just thinking back at your typical doctor's appointment is what, 15 minutes these days? How are you able to individualize care when you're asked to see 30, 40 patients a day? Go, 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 go. And that individualized care is totally lost in that shuffle. Do you think there is a way that system can be disrupted eventually? Because we're not going to be able to sustain it.
Yeah, I mean, leadership like yours, I think, is what can help disrupt the system. I also think a lot about collaborative care.
Mm,
You know, in the current system as it is, if a provider does not have the time to hear someone's full story, how can they provide a warm handoff to someone who can? And how can they provide a warm handoff to, get someone like the social services that they might need? So I think in the current system, like you're saying, there's a real conflict, right, between
mhm,
the bottom line and what is actually healing for people.
mhm,
And I don't have an answer to it, but the thing that I do think about is in the midst of these systems that are functioning the way they are right now, how can we build a net of support? And I also, it ties a little bit back into community education. I also think the more that societally we can be less grief averse
mm,
and more literate around grief,
mm,
more understanding around it, that people can also have friends and family, book club or church community or, women's group or whatever it is that can
mhm,
also come around because grief is so uniquely personal, but it's also deeply communal and
mhm.
we need all of it.
Okay, I'm gonna be a little bit of a devil's advocate here because
Great.
I really want to know what you think in this sense. So absolutely, I believe in allowing people to grieve and take time to grieve. And I think you were the first person that I heard that communicated that grief can come in and out. Like it's not this linear. You
Mhm.
got to go through it and then you come out and then you never grieve again kind of situation. But you can jump in and out of grief. What for the community, for the friends, family, people in this person's life, what can they do to support this person as they come in and out of grief? Because that could be really exhausting for the support system too. And what's the balance between, yes, I'm going to honor this grief that you're going through, but what's the balance between enabling this person
Mm.
that the grief is so intoxicating sometimes that the person completely collapse under it? Because
Mm.
I've seen that too. And my natural, I'm not very good at allowing grief to go in and out sometimes for people in my life, and that's something I totally own because my mentality is like, okay, at some point we got to make some progress here. We got to get through this here because we can't just all collapse under it because life goes on. My life moves on. We can honor that, but at some point it can't just completely encompass you and drown you in it. And my infertility is a part of my story, but it is not the marker of who I am. Like it is a piece of me, but it doesn't define who I completely am, right? How do we find that balance, in your opinion, from a supportive standpoint?
It's a beautiful question. A few thoughts come to mind. One is about Kessler talks about this. He's a grief expert, and he talks about, the role of serving one another in grief is the concept that, okay, you're the one grieving now. I'm going to serve you. I'm going to be present to you. Next week or next month or next year, I'm going to be the one grieving.
Mm.
And so the more I think that we can become comfortable with our own grief and being able to oscillate in and out of it, the more bandwidth we have for other people going in and out of it. And sometimes, like you said, people do get pulled underwater with their grief.
Mm-hmm.
It does fused with identity for some people. And there are different reasons why that can happen. One is sometimes people hold on to pain because if they let go of pain, it means they're letting go of their person. And so helping people, even as a support person, certainly in therapy, this is useful, but even as a loved one, helping people work through that faulty belief. Like you can hold on to your child or your baby or your pregnancy or your dream
Mm.
and hold on to life too. What can a legacy look like where you live and stay close
Mm-hmm.
to this at the same time? I think sometimes people feel like there's an alliance to the person who died or the baby who died,
Mm-hmm.
and that they have to stay in it. And so really giving people permission that
Mm-hmm.
it's okay to keep living and stay connected.
Mm.
There's a grief model, it's called continuing bonds theory. And the
Mm.
continuing bonds theory says that death doesn't end a relationship, death changes a relationship.
Mm.
And that relationship can be dynamic and evolve over time. So how can we be in relationship with our loss while we keep living? And in really practical terms, sometimes if someone is really anchored in their grief or in their loss, sometimes I'll back into it with really, this sounds funny, but with actually kind of negative language.
Mm.
So rather than, hey, I think you need to get up out of bed. I think you need to get outside. Let's go for a walk.
Mm-hmm.
Sometimes people can kind of push back against that, right? Like, no, don't tell me what to do, or I
Mm-hmm.
don't feel like it.
Right.
And so by sort of gently backing in with something like, hey, I see how you're feeling today. I see it's a heavy day or it's a low day.
Mm-hmm.
Does it feel totally out of the question to go for a walk? Does it feel totally intolerable to go sit outside or to go for a drive?
Mm.
And sometimes just using that language can give a little bit of space for people to go, well, I guess not totally intolerable,
Yeah.
right?
Yeah.
So then it's like, okay, is it okay if bring you your shoes?
Yeah.
And so it's like creating a little bit of movement by kind of backing in with like, what is totally out of the question for you today?
Mm-hmm. Mm-hmm.
And then what could be possible?
Yeah. So it's, as you were talking, I'm just thinking of like grief and life. It's and, not or. It's this dynamic that can live within that can be cohesive in one space, that could live side by side. It doesn't have to be a complete suffocation or takeover from this other piece of it, this grief or this trauma that has happened. Because that could be frustrating for the people that are caring for the person that's going through that, and not being burnt out themselves, not being frustrated themselves.
And that's so beautifully said, Helen, about it. It is, David White has a poem where he says, like, grief is the door to the deeper world. And
Mm.
I think deeper world is this world of both and.
Mm-hmm.
It's like joy and loss.
Mm.
It's sorrow and hope. And I think the way you said it is just right. It's helping make space. Like, can can you be with both?
Okay, another devil's advocate question. Do you think our society now, as Americans, I feel like we're so adverse to suffering. We don't want to suffer. We don't want to do hard things. We don't want to feel pain. We don't want, it's just too hard. I don't want to do it. Do you think that has contributed to the disconnect of grief, of feeling true grief and moving beyond that in some way? Do you think that has contributed as a society? We haven't made safe spaces or holding spaces that allows just normal life. In other parts of the world, people suffer. People go through really horrible, horrible things. And yet they're able to move on, or they're able to, maybe in not the healthiest ways. I recognize that. But do you think we have a tendency to enable? Because there's, in my opinion, there is beauty in suffering. There is a beauty in walking through something that changes your heart, that connects you to a community that you did not even think you were going to be connected to. And there's a lesson in that to build character, to sanctify our own beings. And yet we, I think as a country, as a society, sometimes want to eliminate that piece. And has that contributed to this misunderstanding of grief?
100%. 100%. I
Okay.
think I have so many thoughts about this.
Yeah.
Could be a whole
Yeah.
I have a lot of thoughts about this, and I believe that the more we try to make things easy and painless, we miss the inherent wisdom of being human. You know, life is a constant cycle of birth and death and rebirth, and in lots of different ways, right? Metaphorical ways and literal ways. And what I see is that the more we avoid endings or death or decline, and the more we lean towards like ease or distraction or pleasure, I see that the more anxious we become. I think there's something about actually being with the realities of life and death that eases anxiety for us sort of collectively. I know that's not always the case individually, but I
Sure.
think collectively something to that.
Yeah. This has been, again, just fascinating and amazing. I'm just so envious of how you are able to like take my fumbling of a concept and wrap it in beautifully. And I truly feel like we're just kind of picking at the surface of something that we can go totally deeper. We're up to an hour, and I just want to really respect your time. But just thank you so much for always so eloquently putting this beautiful bow on these feelings and concepts that a majority of us are thinking and feeling, but don't know how to do it. So just thank you so much for what you do and your passion. And if I may be so bold as to ask if we could come back and continue to build on this topic, because I think it is something so important that I truly feel like a majority of my patients that walk through the door are dealing with this. They just don't have the words. They don't have a label. They don't have the tools to know how to even broach it. So I think this is a super powerful podcast, and just your wealth of knowledge is going to impact a lot of people. So thank you.
I'm really grateful for your time and for your experience and you being a voice for your listeners and for your patients. I really grateful to have spent time here and yeah, thank you very much.
Thank you. Thank you. I hate to end this podcast, but I just want to be sensitive to everyone's time. Like I said, this is just the beginning process, I feel like, of stepping into something much deeper. Thank you to Megan for all of her expertise and just answering all my blumbering questions. We'll be back, piggybacking on this already amazing conversation. Until next time, guys, thanks for tuning in. For more information about 3W, please visit our website at 3wmedical.org. That's the number 3, the letter W, medical.org. From there, you can learn more information about the services we provide, book an appointment, or make a donation if you'd like to support our mission. You can also call our office at 206-588-0311. That's 206-588-0311. If you like this episode, please share it with others and consider subscribing on your favorite podcast platform so you never miss an episode. Thank you so much for listening, and until next time, stay healthy and be well.